My name is Bishoy Ayub. I am going to present to you today the first primary PCI auditing review. This weekly meeting aims at presenting the statistics of the primary PCI service of Department 23 and evaluating it, as well as learning from our professors the best and ideal management strategies for ST elevation myocardial infarction patients. And my presentation will be divided into two parts. The first part is the statistics of the last week. The second, I will review the clinical and angiographic data of every individual case, and we are waiting for your valuable comments and discussion. This is the summary of the last week. Total number of STEMI cases was 3. This number is low as our cath lab was out of service for 3 days. All the 3 cases went to admitted for primary PCI strategy, and there was no suspected COVID-19 cases, but 2 cases underwent CT chest survey in the ER with median time delay 15 minutes. And the median time delay in the ER was 60 minutes, and median total time delay till revascularization was 70 minutes. We had 1 complicated cases with heart failure at time of presentation. And this is the outcome of the cases. 3 cases underwent primary PCI strategy. 2 had successful PCI. Actually, 1 was only BTCA. 1 had failed PCI. And the outcome was 1 mortality, and that was after the procedure, 0 mortality before the procedure, 0 critically ill patient, and 2 are still recovering, and 0 discharged. And going to the first case, she is a female, 70 years old, with history of diabetes and hypertension, history of ischemic heart disease with PCI to LCX 1 year ago. She presented with typical chest pain of 2 hours duration, arrived at the ER at 2 a.m. She was vitally stable and she had no signs of heart failure. Standard ECG as well as RV and additional RV and posterior leads were done and interpreted within 10 minutes. CT chest survey done within 15 minutes, and she transferred directly to the cath lab, and this cost us 1 hour. Here is her ECG. The first one is the standard 12 lead ECG, showing normal sinus rhythm with ST elevation in lead 2, 3, and EVL. Slight ST deviation, version AVL, and V1 to V3. And the right lead show no ST elevation, and posterior lead show ST elevation in V1 in V7 to V9, indicating
what is the
infraposterior myocardial infarction. For that, the patient sent to the cath lab, and a diagnostic coronary angio was done. We can see here in these 3 views for this system, a right radial approach, and we can see the left main bifurcation with the LCX and LED. We can appreciate a significant bifurcation left main disease, distal left main, ostial LCX and ostial LED, as well as proximal LED significant lesion. And moving to the right coronary angiography, we can appreciate a total occlusion at its proximal part. And as a patient presented with the infraposterior STEMI, attempt for revascularization of opening the RCA was started. And here we can see the guiding catheter with the wire passing the lesion successfully. Then balloon inflation to by 20 millimeter balloon. See here improvement of the flow, TEMI3 flow, with appearing of a thrombus containing lesion at the proximal part of RCA. And here again the final results. But as this patient had left main LCX LED disease. The operator terminated this primary PTCA for total revascularization, surgical revascularization later on.
Main with bifurcation LAD and LCX and total RCA. So when you have this anatomy in a primary PCI, you should go and open the artery that is totally occluded, that got the patient to the hospital, and then manage accordingly. First of all, this patient had a large thrombus burden. No aspiration was done. No aspiration, just balloon dilatation. Usually, we do not like to do balloon dilatation inside the thrombus. Yeah. If we are confronted with such a patient and we are going to stent, we usually stent immediately without doing balloon dilatation, because this will dislodge our fragment. But this result after balloon dilatation, you have immediate flow. So this is accepted, and the patient should be continued on, of course, 2B3A and heparin, and planned for surgery after complete assessment.
Yes.
So this is a surgical patient, but what was done is opening the cardiac artery that caused the infarction. This is appropriate in this patient. What did the patient do after that?
Actually, the patient refused to do surgery, and actually she had the PCI to RCA and to the LAD.
LAD.
Yes.
What about the ostial?
Yes. Total revascularization, doctor. Left main LAD and
left main LAD and LCX.
Yes.
So this was an option.
Yes.
In this patient, برضو يعني, if you are even going to do surgery, why not put a stent in the RCA and finish the job? You could have put the stent in the RCA and finish the job and leave the left system for future decision. Yani, don't leave it like that after balloon dilatation. This is a very big right coronary artery. I would stent it. I would wait for some time accordingly back to surgery or do the left main bifurcation.
Okay.
So is there any comment from the audience who are with us?
Nothing.
Yes, Baghdadi is here.
محمد سيد.
Huh?
لا دكتور محمد سيد هو الأخير.
Okay. خلاص كده احنا no one is commenting.
Yes.
خلاص, let's shift.
Moving to the second case. This is a 70-year-old male with history of diabetes and hypertension, history of ischemic disease, with the PCI to RCA with two drug-eluting stent 2 years ago, and he wasn't compliant on medications. He presented with atypical chest pain of 10 days duration and arrived at the ER at 12 a.m. He was vitally stable, but he had ongoing pain and dyspnea secondary to COPD exacerbation and pulmonary congestion. A standard ECG done and interpreted within 10 minutes. A CT chest survey was done within 15 minutes, and the patient transferred directly to the cath lab within 1.45 hours. And here is his ECG showing sinus tachycardia with white QRS complex with right bundle branch morphology with ST elevation starting from V3 until V6, about 1 millimeter ST elevation. But the presentation of this patient with atypical chest pain and this ECG, the operator was not convinced with STEMI diagnosis. And actually the patient had troponin that was done outside and it was markedly elevated with creatinine elevated the patient, the operator intended to do diagnostic coronary angiography and see what we will have found. Here is the echo of the patient, and this is one of the things that make the operator think that this may be not an acute presentation. We can appreciate here severe depression in left ventricular systolic function with akinetic or apex and all adjoining segment with ballooning and thinning out of the apex. So here is the diagnostic angio of the patient. We can see the RCA, again, right radial approach, RCA free of significant lesion, patent is the previous deployed stent. And here we can see in the right caudal view and the spider view that we had a total occlusion at the proximal of the LED artery. So at terms of revascularization,
the right coronary injection, did it show collateral in the left
no,
system?
there was no collateral. Yes. And here we started the
Going back to
revascularization.
the echo
Yes.
and seeing this lesion, this is probably a chronic lesion. This is not something acute.
Yes. But because there were no collaterals, the operator tried to open the lead. So here an Asahi intermediate, the available wire, started and tried to pass the lesion. And here we can see that it placed distally, but there's no improvement of the flow. And again, here you can see that the wire inserted
The wire
crossed lesion and inserted distally without improvement of the flow. So a balloon inflation with a 2 by 20 millimeter balloon with multiple inflation, but unfortunately that not improved our the lesion.
There is no flow at all.
Yes, no flow. So another wire, PT2MS wire, inserted, trying to probe another side of the lesion to open the lesion. It's coming.
Now, what was the plan of the second wire?
The operator said that he tried to make another track inside the lesion to open the lesion. And again, a balloon
محمد لو
inflation.
تسمح لي اجاوب انا على السؤال ده. I am the operator. انا احمد سمير. تسمح لي يا فندم؟
سمير جاوب.
هو لما عديت بالاساهي intermediate and actually it went smooth. هو انا ما كانش في عندي مشاكل ولا resistance فيه خالص، بس لما وسعت بالبالونه ال 2 by 20 اكتر من مره وما كانش فيه any flow anti-grade، شكيت للحظه ان احنا ممكن نكون من البدايه بالاساهي intermediate going into a very blind zone، ممكن نكون دخلنا into a subintimal track ولا حاجه. وبالتبعيه خدت واير الثاني اللي هو PT2MS وtried my best ان انا direct into a different spot from the site of total occlusion. يمكن هو يكون انا داخل subintimal بالاساهي intermediate and I'm trying to probe another pathway. وبالفعل حاولت ان انا اوجهه ودخلت PT2MS انا دخلت بيه into multiple pathways assuming that they are diagonals and perforators. كنت سايب الاساهي intermediate في مكانه as a mark وبتحرك كمان، وبعد كده وسعت بمره كمان زياده على ال PT2MS but it was same thing. هو ما كانش فيه اي حاجه. apparently this was a very old lesion. ال LED territory كله hard، ما كانش فيه اي flow لا انتي جريد ولا حتى ريترو جريد من حقنات الرايت. فهو بالرغم ان احنا كنا من البدايه كنت شاكك في ان البرزنتيشن بتاعت البيشنت ده انها هتبقى very chronic and mimicking an acute coronary syndrome، وان الاس تي elevation دي ينفع انها تبقى جايه من الديسكاينيزيا والانيوريزمال بارت بتاعت في الايبكس. بس بصراحه يعني قلت ان احنا اتس بيتر ان احنا ندي البيشنت ذا بنفيت اوف داوت، نديله هيز تشانس ونتراي اور بيست ان احنا نفتح له ال اي دي.
بس خلاص انت في النهايه there was no flow بالتو وايرز.
No flow at all.
طب what did you do the ايه بعد كده للبيشنت؟
Actually the patient
هو
was sent to the CC anti-ischemic medication. اتفضل يا دكتور.
هو احنا من البدايه لما كنت بسال البيشنت على البين I was not very convinced بالchest pain بتاعه ان هو resembling حاجه تخص an acute coronary syndrome او acute coronary occlusion. فلما عملنا المحاوله بتاعه ال PTCA لل LAD without any advancements ف limited amount of contrast، ما حبيتش ان انا بقى اخد بالونه اكبر او anything else. رجعنا بالبيشنت على السي سي وبدانا نمانج على ان هو عيان سي او بي دي وهارت فيلير، وغالبا حاصل له ديكومبنسيشن او اكسسربيشن مع ممكن يكون في سوبر امبوست تشست انفكشن. هو كان بيكح كحه رهيبه وكان في عنده تشست سكريشنز بلنتي، فاتعاملنا على ان هو يكون عيان هارت فيلير. بدانا ان احنا نمشي معاه على العلاج بتاعه. الايكو كان بيقول ان الايجكشن فراكشن very depressed in the range of 15%. فكانت المانجمنت بلان بتاعتنا ان احنا apart من ان احنا نكون ماشيينه على دول انتي بليتلتس انما essentially targeting heart failure therapy.
Unfortunately, the patient sudden arrested in the next morning.
In which
asystoly. Asystoly, yes. Without cause, يعني apparently.
The kidney functions did not deteriorate after that.
It's like 10 hours, Dr.
Yes. وكان في urine output.
Yes, he was, according to the resident, he was well perfused, blood pressure was okay, and he suddenly became agitated and attempt of CPR was failed.
خلاص شكرا يا احمد.
تحت امر حضرتك يا فندم، شكرا جزيلا.
Thank you.
Moving to the third and final case, 64-year-old male with history of hypertension and history. He presented with a typical chest pain of 1 hour duration, arrived at the ER at 9 p.m. He was vitally stable with no signs of heart failure. ECG done and interpreted within 10 minutes, and he was transferred direct to the cath lab within 30 minutes. Here was his ECG. 12 lead ECG with sinus rhythm, ST elevation, lead 2, 3, and EVF, and T-wave inversion 1 in EVL. So diagnostic coronary angio was done, right femoral approach. You can appreciate here, you can see the left main bifurcating to the LCX and the LED. We can appreciate here lesion in the proximal to mid LED. We will see it again in the another view, and significant ostial proximal OM, first OM lesion. The RCA, yes, yes, the RCA. RCA totally included.
بس total non-dominant RCA. Most probably.
Yes.
Sir, look.
Code.
But it has an early bifurcation.
Yes. With heavy thrombus burden.
This is only with the wire. The artery opened only with the wire.
Yes.
Or,
yes, the wire. Yes.
Recanalized the artery.
But the very long lesion and the heavy thrombus burden. Yes. You will see now. Direct stenting, yes, actually, with
large thrombus burden.
Yes. By 31 millimeter balloon.
Branch is caused.
Yes. There is a proximal left proximal lesion left proximal to miss. So another stent, overlapping stent, deployed proximal, 2.75 by 20 millimeter balloon, and we can see here after post-dilatation, the final result on the right side with the actually this was the last I will check.
ممكن نراجع تاني بس دي والسيرف الأوفر.
The patient was
resubmitted.
planned to further revisation for the left system. That actually did it 2 days ago.
The LAD and the OV.
Yes.
You only do the culprit, or do you do complete revascularization in the setting of a primary PCI?
Okay.
A very small presentation.
Okay.
Week after, we are going to do a presentation about thrombus aspiration.
Okay.
Do we do thrombus aspiration or not? And what do the recent guidelines tell us?
Okay.
Okay. So, very short presentation.
Okay.
10 minutes before we begin reviewing cases.
Okay. Okay. Sure. Thank you so much.
Thank you. And if anyone has any questions, you are free to ask. How many?
17. 17.
Okay. Good.
Okay. Thank you so much.
يبقى المرة الجاية نعمل اللي هي to do only the culprit versus